Hi, my name is Cayton, and welcome to this presentation on effectiveness of instrument-assisted soft tissue mobilization in high school female soccer players with anterior hip pain. The number of athletic exposures continues to increase, leading to greater concern of risk for injury, of which most of these injuries are overuse in nature due to high training volumes. Non-contact overuse injuries to the thigh and upper leg are the second most common injury following incomplete ankle sprains, of which the majority of these injuries occur in practices rather than games. Lower extremity movement dysfunction, specifically altered muscle activation, has been reported in both healthy individuals and individuals with groin or anterior hip pain. However, a gap in the literature exists between the patient population that has been studied to date and the need for lower extremity muscle activation patterns to be assessed in a non-healthy adolescent athletic population such as high school female soccer players. Currently, there is no gold standard for treatment or assessment of insidious onset of anterior hip pain in adolescent female soccer players. The use of instrument-assisted soft tissue mobilization has not been studied in this particular patient population. However, it has been studied in other musculoskeletal conditions in which it has been proven to be effective in improving children range of motion and also pain and function with IT band syndrome. Hip and core strengthening exercises to correct poor movement patterns have been studied in runners with femoral acetabular impingement and musculoskeletal models and healthy women. The patient-specific functional scale has been valid and reliable in other musculoskeletal conditions. However, using this measure with patients with hip pain, there has been no reported minimal detectable change or minimum important difference, which may create a limitation when determining if improvements have been made due to the interventions. Identifying the current gaps in the literature now lead to this clinical question. In high school female soccer players with anterior hip pain, is the use of instrument-assisted soft tissue mobilization in conjunction with a hip and core strengthening exercise program more effective in improving patient-reported pain and function compared to instrument-assisted soft tissue mobilization alone? High school female soccer players aged 14 to 18 years old will be recruited for the study, which will occur at the initial point of contact when the patient reports onset of anterior hip pain to the athletic trainer or primary investigator. Inclusion of patients into the study must meet one or more of the following criteria: complaints of anterior hip pain within 2 weeks of onset. The mechanism of injury must be ruled as overuse or insidious onset of pain by the athletic trainer. Patient reports pain with active and passive hip flexion. A modified Thomas test results in a positive test for either TFL, rectus femoris, or iliopsoas stiffness. There's a positive test result for anterior movement of the greater trochanter during an active straight leg raise, and a positive test result for faulty movement activation pattern with or without pain during the performance of prone hip extension. Patients will be excluded from this study if they meet one or more of the following criteria: any lower extremity injury within the past year, any lower extremity surgical procedure in the past year, any physician-diagnosed neurological disease or disorder, the patient is currently receiving treatment from another healthcare provider, there is a negative test result for anterior movement of the greater trochanter during an active straight leg raise, a negative test result for faulty movement activation pattern with or without hip pain during the performance of prone hip extension, and a negative modified Thomas test for stiffness of the TFL, rectus femoris, or iliopsoas. After approval of the local institutional review board and the Diocese of Dallas, patients will be recruited into the study at the initial point of contact, as discussed in previous slides. Parental assent and/or patient consent forms will be signed, and the patients and the guardians and parents of patients will agree to randomization in this point-of-care clinical trial. Outcome variables within the study are the numeric pain rating scale, the lower limb functional index, the patient-specific outcome scale, the patient-specific functional outcome scale, which will all be administered at the first treatment session. However, the numeric pain rating scale will be the only measure to be administered every treatment session. The other two measures will be administered every 2 weeks until discharge. The intervention group will include Graston technique plus hip and core strengthening exercises. And the comparison intervention group will include Graston technique alone. Each intervention, dependent on which one is assigned to the patient, will be delivered 2 times a week until discharge. Stakeholders within this point-of-care clinical trial will include patients, parents and guardians of patients, the head athletic trainer, athletic director, and president of the institution in which the point-of-care clinical trial will be taking place. Other stakeholders include manufacturer of Graston technique instruments and the head and assistant girls soccer coaches. Epidemiology studies have reported on injuries to the pelvis and thigh caused from non-contact overuse injuries due to high training volumes in adolescent soccer players. This continues to be an area of concern with the increasing athletic exposures of youth and adolescent soccer players due to year-round participation in either their interscholastic teams, academy teams, club teams, in addition to weekend showcases. Point-of-care clinical trials are needed to investigate the causes of anterior hip pain in female adolescent soccer players and the effectiveness of the interventions to improve pain and function to support athletic training practice. Currently, there are no studies in this patient population to support the effectiveness of these interventions, and there are currently also no studies, to my knowledge, that investigate faulty movement dysfunction and corrective exercises to improve these dysfunctions in this particular patient population. Implications for athletic training practice are dependent on which intervention is more effective. Overall, the feasibility of this study is good. However, there are some foreseeable challenges with the implementation of point-of-care clinical trial due to the current EMR requiring upgrades to be compatible with the point-of-care clinical trial and adaptive randomization process. Timeliness to complete outcome measures is very good. The time for the patient to complete the outcome scales and also for the primary investigator or athletic trainer to score the outcome assessment scales should take in totality less than 5 minutes. Although the primary investigator may face time constraints, these can be overcome with time management, support of the stakeholders, treatment session schedules, and confirmed appointments with the patients and parents and guardians of the patients. However, due to the high cost of basic training courses to adequately deliver Graston technique, this may also become a challenge due to the high cost of the training program and may be something to consider. Athletic training practice implications are dependent on which of the two interventions are more or least effective in improving pain and function in this patient population. For example, if instrument-assisted soft tissue mobilization, in addition to hip and core strengthening exercises, are found to be more effective, then this information is very valuable to the athletic trainer and can justify spending more one-on-one time with the patient to assess and treat these movement dysfunctions, muscle stiffness, and also to engage the patient with outcome assessment scales to determine the level of disability. However, although the cost of Graston Technique basic training courses is fairly high, if the results of this intervention group is found to be effective, then the cost for these type of training courses can be justified. We can also look at patient compliance being achieved and the reduced time loss for injury, which ultimately would increase patient satisfaction, although this was not an outcome variable within the study. This could be something that could be further investigated in future research. If instrument-assisted soft tissue mobilization alone is more effective, then again, this can validate the use of looking at muscle length and stiffness as a commonly used assessment tool when assessing patients with anterior hip pain, and also can justify the cost for Graston Technique training. Due to one intervention needed, instrument-assisted soft tissue mobilization plus hip and core strengthening could also be found to be the least effective intervention. And in this case, then we should begin to think about the need for possibly more adequate assessment batteries for insidious onset of anterior hip pain, looking for more efficacy studies and comparative effectiveness research on proper exercise selection to correct these faulty movement patterns and movement dysfunctions. The use of another form of instrument-assisted soft tissue mobilization could also be warranted. A few other challenges that could have contributed to the non-effectiveness of these interventions are small sample size or poor patient compliance or dropout, missed treatment sessions, possibly a lack of training in Graston technique. And these are some limitations that, again, need to be investigated in further research so that we can find an intervention that will improve pain, improve function in these high school female soccer players. So in summary, the big takeaway points are that to date there isn't a lot of evidence to really determine how to assess and treat anterior hip pain in female high school soccer players effectively. There's also a need to monitor improvement with patient-reported outcome measures, and also a need for stakeholder support to aid in the success of this type of point-of-care clinical trial, whether through financial support, encouraging patient compliance, being supportive of missed games and practices, and also ensuring that the safety of the patients is the number one priority. So the findings of this study can definitely drive future research in determining what interventions are going to be most effective for treating and assessing anterior hip pain in female soccer players. This concludes this presentation, and the references are included on the last two slides. I look forward to continued discussion regarding this topic. Thank you.